This is Dr. Michael Dougherty with Performance Spine and Sports Medicine. I'm the chiropractic physician here at PSSM. This presentation is geared towards other healthcare providers, whether you're a medical physician, surgeon, or physical therapist, to just kind of understand the role that the chiropractor plays in patient care. The title of this is Chiropractic Practice and Patient Management. So what is chiropractic? Of course, we hear a ton of questions, hear different things. Is chiropractic just manipulation or adjusting? In my opinion, no, it's not. It's primarily conservative, non-surgical management of neck pain, back pain, and headache. We also do evaluation and treatments of other musculoskeletal injuries, not necessarily with manipulation. And of course, is it all about lifetime treatments? Absolutely not. We tend to stick with a normal care plan that you would find in any other physical therapy department. So what can you expect? Well, patient intake obviously is very similar, if not the same as everybody else. We're going to look at the history of present illness, of course, review their past medical history, as well as go over the review of systems. We'll get their contributory family history, social history, and of course their vitals. From there, we do a neurologic screen, including cranial nerves, depending on the patient's chief complaint. So treatment is based on evidence. We use what's called the Diagnosis-Based Clinical Decision Rule, or the DCDBR. This was formatted by Dr. Donald Murphy of the Rhode Island Spine Center, along with a few others back in 2007. Basically, we start off by asking three simple questions. Are there any red flags? Now, based on the current literature, red flags will present to a chiropractor's office about 2.7%. From there, we rule out the red flags. We're looking at what are the pain generators. There's certain pain generators we look for specifically when it comes to spinal pain. We'll go over those. And then we look at yellow flags. What other things contribute to this patient as a whole that would lead to the presentation of pain? So red flags, of course, any symptoms of spinal pathology that are caused by more sinister conditions, cancer, tumor, or some other space-occupying lesion. We're looking for loss of bowel or bladder control, saddle paresthesia, or urinary retention. Of course, we want to check our long track signs. We're looking for upper or lower motor neuron lesions. History of AAA or presentation suggestive of a AAA. Of course, gross motor loss. We generally use the criteria 3/5 in terms of strength, and progressive neurological deficits that are either outside our scope of practice or not responding to the treatment. So pain generators in the spine. Generally, we put everything into four categories to try to kind of centralize the patient's care. So we're looking at the nerve root, and this would be typical with your acute radiculopathy patients. Of course, the disc, which can be multifactorial in terms of an acute presentation or chronic presentation. We look at the facet joints as well as the SI joints, and of course the muscles, usually last and sometimes the least. So the contributing factors, we talked about the yellow flags earlier. We're looking for craniocervical or lumbo-pelvic instability, which is essentially just poor motor control or quote-unquote core control. We also look for things like fear avoidance, passive coping, depression, and usually we find this out based on some outcome assessments that we usually give the patient prior to seeing them. Of course, central pain, hypersensitivity, again, a topic that some know a little about. And I think the research is kind of up in the air still. But generally we see this a lot with post-MBAs or major traumas. So in terms of the nerve root or your radiculopathy, obviously we want to look for our neural tension signs, straight leg raise, well leg raise, slump test. All of these are very sensitive but not very specific, so you may have to further delineate with other testing such as EMG or NCV studies. Generally we're going to find pain below the knee, and again this isn't clear cut, and these would be the non-responders to directional preference, which would be a McKenzie assessment, which we'll also talk about. So disc derangement I find is one of the most common presentations, especially for acute back pain. We know that acute back pain, the disc is involved in approximately 80% of people with acute symptoms. So the way we generally evaluate disc patients is with a McKenzie protocol for directional response. If you're not familiar with Robin McKenzie, he was a New Zealand physiotherapist who came up with a way to diagnose and manage essentially acute disc derangement patients. What we typically find with a disc derangement is that it's, again, axial in nature. Occasionally you can have radiation, not usually below the knee, but of course everyone's seen stuff that doesn't quite fit the cookie cutter model. There's generally going to be an absence of neural tension signs, no burning, leg pain in the dermatomal distribution or anything regarding that. And generally we'll see pain when rising from sitting or pain with prolonged sitting and posture. So the facets and SI joints get a little hairy occasionally. I think sometimes they're overdiagnosed and sometimes they're underdiagnosed. So with the facets, we're obviously going to base it on patient history. So pain with extension and provocative testing to the facets, like your Kemp's exam or even just a facet loading a test. For the SI joint, and we'll get into this on the next two slides, we use Lazalet's criteria, and that's generally 3 out of 5 positive exam findings on the 5 tests that they deemed were the best tests for the SI. That includes Gainsland's sacral thrust test, iliac compression, thigh thrust test, and a distraction. Now with the lumbar Z joints, that's associated with absence of pain when rising from sitting. So we talked about the disc was going from a sitting to a standing position. Generally the Z joints will be from the absence of pain with rising from sitting. Whenever we talk about the SIs, and I'm overlapping here a little bit, we want to rule out the derangement first. So the primary thing we want to make sure is not going on is the disc derangement. A lot of times disc derangements will mask as SI symptoms because of the nature of radiation with the disc. So we'll talk about this again, that the sacroiliac joint, it's related to 3 or more positive findings, pain when rising from sitting, and usually unilateral pain without any lumbar pain. So it typically will be under the lumbar spine, and there shouldn't be any lumbar pain, although again we could have multiple areas affected. So with the SI joint clinical prediction rule is a test that was, a battery of tests that Dr. Lazalet came up with. He finds if there's 3 or more positive provocation tests with the absence of centralization, so they ruled out the disc, the diagnostic performance is improved. Their statistics say that the false positive rate is decreased in specificity from 78% to 87%. So basically low back patients that satisfy this criteria, they have a probability exceeding 70%, and if we apply this to pregnancy-related low back pain, it's probably closer to about 90%. So the last pain generator in the spine we look for is myofascial pain, trigger points in the muscles. Occasionally we do see them as primary pain generators, but I find they're rarely the primary source, and generally it's secondary to something else going on in the spine. You can review Dr. Travell's work, which she basically mapped out all typical referred pain patterns. And then you would apply, of course, myofascial therapy, stretching, things of that nature to if it was solely myofascial pain. So treatment strategies. Chiropractic physician, we're trained in diagnostic imaging and assessments. We're able to order advanced imaging in labs if need be. Of course, the idea is to refer to the preferred specialist when necessary, and we're often combined in a physical therapy setting with other medical physicians. At Performance Spine and Sports Medicine, we have physiatrists, physical therapy, and chiropractors all under one roof, so we're able to kind of inter-refer and get each other's opinion on certain difficult cases. So again, treatment strategies. Of course, we're going to see the patient 3 times a week for the rest of their lives, right? That's what you guys hear typically with chiropractors, but again, that's not the case. We'll utilize what's generally recognized as normal in the PT realm. So we're looking at 2 to 3 times a week for about 4 weeks. If we're not seeing outcomes in 6 to 8 treatments, we're generally going to change our treatment or make a referral to get something else in the picture if we're not quite getting where we need to be. And the patients usually discharge, obviously based on pain. Sometimes they disappear, but also based on outcome measures. So we use the Bournemouth, we use the Oswestry, we use the Neck Disability Index, along with many other things to kind of determine where the patient started versus where the patient is now. So with advanced imaging, I'm sure most everybody who tunes into this presentation knows this, but we're only going to order the MRI in presence of serious or progressive neurological deficits when something underlying is suspected, or when considering surgery or an epidural. So again, we have that buffer of probably 3 to 4 weeks. We know that, again, based on the literature, that the sinister pathology is probably less than 3% of presentation to our office. So we'll make the call to order the MRI if we deem it necessary. And again, should we have a patient that's not responding to care the way we'd like them to, and we do think they could benefit from an epidural or possibly even surgery, then most of the time we'll go ahead and order the MRI and then send them to the surgeon or physiatrist for their evaluation. So guidelines also endorsed by the American College of Occupational and Environmental Medicine. They recommend the MRI only in the presence of focal neurologic symptoms that persist for at least 6 weeks and are not kind of trending towards upward improvement. So again, just another thing to keep in mind when ordering MRI, especially if a patient presents without having undergone any conservative treatment. So with the diagnosis-based clinical decision rule, to come up with very simple algorithms. I won't bother to go through the algorithm, but essentially we're going to look to rule out the red flags first, identify the pain generator, number one being the disc and nerve root, and then after that look towards the facets, the SI joint, and possibly muscles as well. So in terms of chiropractic integration, we know the total annual cost of low back pain approaches $100 billion in the United States. The healthcare system is under a tremendous amount of not only change but stress as well. So the non-surgical management of the spine saves, orthos, neuros, surgeons, it saves them time. If it's not a surgical case, why bother going to a surgeon? Go to someone who is a non-surgical specialist that can potentially help, or get you to the surgeon when you need to get there. Our evaluations are based on current available evidence, and of course, again, our referrals are made when necessary. We're located at Performance Spine and Sports Medicine, 4056 Quaker Ridge Road, Suite 111. It's in Lawrenceville. Again, for the other physicians who tune into this, or the physical therapist, or any other health professional, please feel free to email me with any questions you may have, or if you'd like to know about some of the other things that we do here, my email's located right at the bottom here. And that's it. Thank you very much.